Good afternoon, and thanks for joining us today. I'm Dr. Erdle, and I'm an orthopedic surgeon with OrthoVirginia, and I'm going to be talking today about meniscus tears. And if I have a meniscus tear, do I need surgery? So let me start by giving a brief introduction about myself. I'm originally from Richmond. I grew up in this area in Goochland County, went to high school in town at St. Christopher's. Went to UVA for my undergraduate degree, and then was back here in Richmond for medical school. Joined the Navy and did residency in orthopedic surgery from 2010 to 2014 down in Portsmouth, Virginia. And then had a Navy career that spanned 5 years after that, spending a couple years in Yokosuka, Japan, a year in 29 Palms, California, and then 2 years in Naples, Italy, practicing general orthopedics. Sort of all over the body, but seeing a lot of knee and shoulder sports injuries, which sort of piqued my interest and led me to go to fellowship down in South Carolina with the Steadman Hawkins Clinic down there. So going into meniscus tears and meniscus pathology, it's important to first discuss what the meniscus actually is. The meniscus is a cartilage structure. There's two of them in each knee, a medial meniscus and a lateral meniscus on the inboard side of the knee and the outboard side of the knee of each knee. It serves as a shock absorber in the knee. It's a softer cartilage than the cartilage we have on the end of our bones. And it also provides some stability to the knee. If you look at this picture in the middle of the screen, this is a picture of a knee taken arthroscopically with a camera inside the joint. The structure on the top is the femur bone, and the structure on the bottom is the tibia bone, both of which have articular cartilage, which is a hard hyaline cartilage. And then the structure you see going from the back and wrapping around the right side of that picture is the meniscus, which is triangular in cross-section and C-shaped if you're looking at it. And what that does, if you look to the next picture to the right, is it disperses the force of the round femur bone across the flat tibia bone. And you can imagine with that softer shock absorber structure in place, the force is going to be distributed more evenly across the flatter surface of the tibia. In contrast, if a meniscus is badly torn or removed, there's concentration of force at a single point as opposed to being dispersed. And then if you also imagine that round structure is having mobility as our knees do, being able to flex and extend, pivot and roll, the meniscus is able to provide stability to the knee joint as well. In addition to structures like the ACL, which restrain motion, the meniscus plays an important role in that. So the cartilage structures that our meniscus protects have a pretty interesting architecture. You can see an image of the St. Louis arch down in the bottom left, and if you look at the pink picture in the bottom right, the orientation of our cartilage cells changes as it gets closer to the surface, where it's fairly flat in the tangential layer and more vertical as we get closer to the bone, which is at the bottom of that picture. So the goal of our meniscus in dispersing our force across a 3D array and matrix of these arch structures is critically important. I want to show you a model that may make this a little more sense in 3D. This is a structure of a knee with this fibula being on the lateral side, the tibia being your shin bone, and the femur, the white bone up top, having this articulation with the patella in the front, and the meniscus is this structure that lives both on the medial side as well as the lateral side. And if I flex this knee down and show you an angle, you can see how both the medial meniscus and the lateral meniscus have this C shape, which disperses the force of these rounder structures of the femoral condyles across the flatter surface of the tibia. And you can imagine when the knee flexes and extends and pivots that there's both a stability aspect as well as a shock absorbing aspect to this important structure. So we can go back to slides now and go to the next slide. So what are meniscus tears? Well, unfortunately for our knees, as time goes on or with an acute injury, the meniscus can see more force than it can withstand. So tears can be acute. They can happen in someone young who's a wrestler or has a pivoting injury, or they happen over time as the meniscus sees wear and tear and the cartilage structure changes as we age. In the setting of arthritis, the meniscus may get worn and torn by uneven surfaces in the joint, whereas when we're younger and the cartilage surfaces are smooth, an acute injury can cause a tear. Typically, these are twisting or pivoting injuries. Frequently, someone will be standing up from sitting cross-legged or pivot to get out of a chair, or if they're playing a sport, they may have a concomitant ACL injury, which causes a subluxation of the knee, which puts an increased amount of force across the meniscus, causing it to tear. How do you know if you have a meniscus tear, or what are the signs or symptoms? The signs and symptoms would be acute pain at the level of the joint line, a sense that there is something off or mechanically blocking the knee. A lot of times we talk about catching or popping, snapping or locking as being the symptoms that patients come in that tip us off that we may need to look and think about a meniscus tear. We diagnose them and confirm them with an MRI, which is magnetic resonance imaging, where we use magnets to assess different tissues in addition to the bones that we see on X-ray, where we can get a good look at the soft tissue structures like the meniscus. So if you look at the image on the top right, that's an example of a meniscus tear. We'll see a lot more pictures throughout this slide deck that are going to show you the different types of tears. But then if you look at these images in the center of the screen on the bottom, you can see a normal meniscus as well as a torn meniscus on MRI. And you can see that triangular black structure in cross-section in the image on the left is disrupted when you compare it to the image on the right, where there's this white line of joint fluid and signal within the meniscus and an uneven appearance of that undersurface of that triangular shape. Moving on to the next slide. How do we decide how to treat these? Well, it really depends. It's a broad spectrum of injury and condition where our treatment depends on a lot of factors. One of those is the type of tear. Another one is the type of patient and the patient goals. The simplest treatment for a meniscus tear would be to simply, watch and wait, see if it calms down, has a propensity to heal on its own. A lot of these will become asymptomatic, or they may have been present before symptoms started. And if we can get inflammation under control, it may still be a torn meniscus or a healed meniscus. But if it's not a symptomatic meniscus, that may be a good treatment for a particular patient. We have different types of tears that affect our decision-making as well. As you can see on this bottom left picture, this is a bucket handle tear, and it's hard to understand why we call it that looking at a two-dimensional picture. But if you go back to imagining that C-shaped structure, if you picture that as being the handle on a 5-gallon bucket that's normally attached to one side sitting on the side of the bucket, if it tears in a certain pattern, that bucket handle can flip over to the other side. And if that flips over into the middle of the notch, it can cause pretty significant mechanical symptoms, pain and locking in the knee. And that's the type of tear that we would be more aggressive about treating, whether it's with a repair or debridement. In contrast, if you look at the second picture where there's fraying of the meniscus has almost a crab meat appearance where it's sort of shredded. That's one that we would consider more of a degenerative pattern. It's one that we would be much more conservative with in terms of trying to see if we can get inflammation controlled in the knee, if we can alleviate mechanical symptoms, and if not, the opportunity still exists to do a surgery and to debride that tear. Other types of tear, that third image shows what's labeled as a flap tear in this picture. Some will call that a parrot beak tear, which you can imagine based on looking at that picture why it was named such. That's one that has the potential to cause mechanical symptoms as well, and may be treated best with surgery if symptoms aren't alleviated with conservative treatment. And then finally, that image on the bottom right, you can see the meniscus is almost completely transected with a radial tear, and that's a type of tear that may be amenable to surgical treatment as well in the right patient. So patient factors play a huge role in this as well. If there's already significant arthritis in the knee, we tend to be more conservative with treating these, understanding that the goal of the meniscus or the function of the meniscus is a shock absorber and stabilizer to protect cartilage. If the cartilage is already in rough shape, we don't need to be quite as aggressive as with treating these surgically and often in a lot of situations. So let's move on to the next slide. How should we treat meniscus tears? Keeping in mind what we saw in the last slide and all the different types of tears, we can treat them once we get to the decision of deciding on surgery with either cleaning them up or doing a partial meniscectomy or a meniscal debridement, which are three terms for the same surgical procedure. We would be more inclined to do that if we know that the meniscus doesn't have the ability to heal. That determination is frequently made in the operating room. Sometimes we can get a good idea from the MRI, but in the operating room, when we're looking and probing this meniscus, we can determine if the tear extends into an area where there's blood supply. And if you look at the images on the single image on the top right of this screen, this is an image with dye that shows the capillary blood supply that nourishes the meniscus and gives it the ability to heal. And you can see that in the peripheral part, or the wider part of this triangle where the meniscus is attached to the capsule, it has a very rich blood supply, which means if we're able to do a repair and hold that meniscus in place with stitches, the body has the ability to heal itself. However, when we get further into the central part of the meniscus, the thinner part of the triangle that's further away from the blood supply, which comes from the capsule, we could put stitches in that meniscus, but it's got a very low ability to heal itself, so our repairs are much more likely to fail, which could require another surgery. So if we see a tear and know that it doesn't have an opportunity to heal, we're much more likely to trim out a small part of that meniscus so that we can alleviate those mechanical symptoms in a single setting. Let's move on to the next page. So I've mentioned a couple different types of surgery for meniscus tears. One of them is meniscectomy, or partial debridement of a meniscus. You can see that this was one of those flap tears that we saw from a couple of slides ago. And it's in this white zone of the meniscus as opposed to the peripheral red zone with blood supply. And in this situation, in this diagram, we're demonstrating a partial meniscal debridement where arthroscopic scissors or a shaver are used to take out the type of blood or the type of meniscus that doesn't have the ability to heal. In contrast, in the picture on the right, you can see this tear is more peripherally located. It's closer to the capsule. It's in this red zone of the meniscus where there is good blood supply and good healing potential. And stitches can be placed in a variety of ways to bring that meniscus back to where it should be after roughening up the edges, promoting some bleeding, to help promote the body's ability to heal this meniscus by holding it in place with a surgical repair. So I've got a few different slides here that show different types of tears and the treatments for them. The first diagram that we saw several slides ago was a bucket handle tear, and it was hard to appreciate on that two-dimensional image why it's called a bucket handle tear, but here I think it's a little more apparent. You can see in image A here, the meniscal tissue is actually in the middle of the joint, not in the peripheral of the joint. That C shape has been flipped 180 degrees, and that's because a tear of this meniscus has extended wide enough where there's a part of the meniscus that's not attached to the capsule any longer that's been able to flip into the middle of the joint. A patient with a meniscus tear like this may notice significant loss of range of motion, or what we would call locking of the knee. Sometimes a patient will spontaneously be able to unlock this by twisting the knee or forcing it straight or forcing it into extension, but that can be pretty painful and it may not alleviate symptoms. It may continue happening, or it may get stuck in that position and not be able to be unlocked. And that's a situation where we would typically recommend surgery to get that meniscal tissue that's blocking motion in the joint back where it should be, or removed from the knee in entirety. And in this type of repair, they've been able to repair that meniscus. In the second image, you can see they're working behind the tear, probably with a probe just showing us what's going on, but we would also roughen those edges up with a rasp, trying to promote bleeding and healing tissue. And then once we've had the meniscus tissue prepared, we would then do a repair using the stitches that you see in image C, where there's multiple stitches placed arthroscopically, holding that tissue back where it came from, and you can see a restoration of the normal C-shape morphology of the meniscus. Moving on to another example on the next slide. This is a radial tear, which is a tear that extends through the meniscus and is, the type of tear that renders the meniscus pretty dysfunctional. You can imagine that if the C-shaped structure stabilizes and absorbs shock from the femur onto the tibia, if there's a complete transection of that or a complete tear of that, its ability to do its function is completely compromised. In the more central region, the tissue may not have the ability to heal, but more peripherally it will. So in this situation, we would likely debride some of that bad tissue from the central part of the joint, or the central part of the meniscus, and then do a side-to-side repair using various suture constructs to restore the hoop strength and the hoop stresses of the meniscus. And that's what you see here with an all-inside anchor deployed here in figure B, spanning across from one side of the tear to the other, which can then be tensioned down under our visualization to bring those edges together. And then in C, you can see they've placed not just one, but multiple of those stitches, probably in an interlocking fashion to repair that meniscus and give it the best chance to heal. On our next slide, we can see yet another type of tear, and we haven't seen this one yet in this presentation. This is a pretty complex tear where there's a horizontal cleavage plane tear, or a horizontal tear, where this triangle has split, leading to a sort of a superior fragment and an inferior fragment. And there's some delamination or splitting between the layers of the meniscus. And you can see here, this is another tear where the surgeon has decided to debride the central part, which doesn't have good healing capacity, where there may be unstable flaps that won't heal, to expose the tear at the peripheral section where there is good blood supply, and then performed an all-inside repair. So again, in figure A, you can see some of this tissue has already been debrided. That's a shaver on the right side of figure A. And then in figure B, they've placed a stitch that's anchored both above and below the meniscus, and which spans this horizontal tear. And then after placing several of these anchors in place, they're able to bring that tissue back together to give it an opportunity to heal. So I think I've got one more type of tear repair to show you on this page, and this is a root avulsion, or a root tear of the meniscus. And this is a type of tear that involves the very back part, typically, of the C shape, the one that's in the back of the knee. Posterior root tears are the most common types of root tears, and they also render the meniscus unable to do its job effectively, because when you lose that anchor point, you can see the meniscus expand more than it should in order to disperse the forces. So in this situation, if there's good cartilage in the joint that we need to preserve and the meniscus tissue is in good shape, we'll place one or two, sometimes more, sutures through the meniscus. And you can see in figure B, these have been placed in what we would call a luggage tag fashion, where they're passed through and then looped through each other to get a good grasp on this meniscal tissue. And then it's repaired by drilling a tunnel into the tibia that comes out the front of the shin, at the proximal part of the shin, close to the knee, and is then either anchored into the bone or tied over a button or tied over an anchor, with those sutures pulling the meniscus back down into a socket where there's bleeding bone, where it's got the ability to heal. So we've seen the different types of treatments for meniscus tears. After surgery, or even if you don't have surgery, physical therapy is likely to be part of the rehab and the healing in the setting of a meniscus tear. Based on what we do, it depends on how much we need to protect the knee. We want to get our patients moving, walking, back to sport, back to activities, back to function, back to their daily life as soon as possible. But if we've done a meniscus repair, we need to slow things down. We need to give the meniscus an opportunity to heal. We've done the structural work by pulling the pieces back together or anchoring them back to bone. But ultimately, we need to let the body heal itself once we've got things back in the right spot. So we'll protect our repairs based on the type of repair that we do. If we do a debridement, someone's going to be weight-bearing is tolerated immediately. They'll be off of crutches as soon as they can tolerate. They'll be in a soft dressing leaving the surgery center, and they won't have a brace on. In contrast, if we do a repair, and if it's a repair of a small longitudinal tear, they may be wearing a brace and limited weight bearing for about 4 weeks. If it's a more complex radial repair, we may protect that for a little bit longer by keeping them on the crutches a little bit longer and restricting their motion for a little bit longer. Our meniscus tears, when we do a repair, they have about an 80% success rate, and that's reliant on the body healing these repairs. So we're a little bit more conservative in protecting these early on because we want to optimize our success rates, give biology the time to do its job, and hopefully optimize that success rate as much as possible. So finally, some folks, I imagine if you're watching this, you know somebody, or you yourself may have a meniscus tear, and you may have heard the different ways these are treated. You may have a buddy that's had it treated. As hopefully you've gained from our talk today, every patient and every meniscus tear is a little bit different. And sometimes we'll see meniscus tears in the setting of bad arthritis or tears that are complex enough that we know that a repair is unlikely to improve patient symptoms. Even though we can make a patient different with surgery and change anatomy, it may not change the outcome. And in some cases, when arthritis is really bad, we think of this as the horse is already out of the barn. Are we doing the right thing by repairing a meniscus if there's no longer cartilage that's worth protecting? So what do we do in those situations? Well, it's not that we have no options. If we're not doing a meniscus debridement or repair, there's still a lot that we can do for the knee. That involves, on the conservative side, modifying activities, doing therapy, and then potentially offering injections. And we've got different types of injections we can do as well. These might involve steroid injections, and our bodies make steroids in our adrenal glands, and the medications that we inject are similar, and that they have an anti-inflammatory property to them, and they can help improve symptoms and pain related to meniscus tears, which then may allow us to get back to strengthening physical therapy activities, and have really good quality of life despite having a tear. We also have viscosupplementation injections, which have some literature that supports that they're very effective for meniscus tears in the setting of arthritis. And then there's other injections coming forward that we're still getting more information about and still gathering literature on that you may hear of, such as PRP injections and others. In terms of surgical options, in some folks, if a meniscus is not repairable or has already been taken out, we can do things to offload the side of the knee that does not have a functional meniscus, such as realigning the bones to transfer weight from a diseased medial side to a non-diseased lateral side, or vice versa. So we can do osteotomies, realignment procedures to realign the bones. As patients get older, it's possible that we need to replace the joint, and that can be done either partially or with a total knee replacement, depending on where the cartilage disease is. And then in a young patient who still has good cartilage in shape, but a bad meniscus or a meniscus that's been taken out, meniscal transplant is another option, where we take a cadaveric meniscal or a cadaveric meniscus and then put that in someone's knee to try and salvage the function and the long-term outlook for arthritis in the joint. So that concludes what I was prepared to talk about. I'd like to open the floor up to questions, the floor is open.
Thank you so much, Dr. Erdle. We will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will get through as many as we have time for. Our first question is, what is the difference between a torn meniscus and a torn meniscus root?
That's a great question. I don't know if we have the ability to go back in slides, but you'll hear the terms, I don't want to say used interchangeably, but if someone has a torn meniscus root, I would say they have a meniscus tear. And if you go if you go forward a little bit, we'll go to the root tear slide, which was the last of those sets of three. A meniscus root tear here we go. So a meniscus root tear is a type of meniscal tear, but it's one that we treat a little bit differently and one that we think of a little bit differently because it's not always a tear of meniscal tissue. In fact, sometimes the meniscus can tear and pull bone off, so it's actually an avulsion of the bone where the meniscus is attached. Other times it is a meniscus tear, but it's torn so close to the root that we can treat it like it's a root tear, where we treat it by repairing it through a bone tunnel by anchoring the meniscus back to bone, as opposed to repairing the meniscus back to itself or back to the joint capsule. So that's an excellent question. I hope that answered it.
Thank you. Are there ways to reduce the risk of tearing your meniscus?
That's also a good question. And I would say there probably are. I think that the best way to reduce the risk of tearing your meniscus is maintaining a healthy lifestyle, staying active. We see meniscus tears more often in folks, and I'm talking about degenerative tears here, and folks that develop arthritis. Now, there's a big part of that you have no control over, and that's your genetics and what you put your knee through over the course of years and decades of living on it. But maintaining a healthy body weight and staying active, I think, is probably the best way to lower your risk of having the development of arthritis and seeing degenerative tears in the meniscus. Otherwise, the reduce of tearing your meniscus can be reduced by having instability issues in the knee addressed if and when they develop. For example, we know that folks who have ACL ruptures and continue to have ACL insufficiency and buckling episodes in the knee are putting their medial meniscus at risk, because as I talked about early on in the presentation, the meniscus is a stabilizer of the knee joint. And if there's increased instability of the knee joint, that can increase the forces that the meniscus is being asked to withstand. And ultimately that can lead to secondary tears, particularly of the medial meniscus, if this goes untreated. So there are ways to reduce the risk of tearing your meniscus, but the way this question is being asked, I would say ultimately a lot of this is genetic. The meniscus typically tears with an injury or is degenerative in nature. There's not a medication or a supplement that is going to lower the risk. It's more of a technical answer than that. I hope that answers that question.
Thank you. Can you tear meniscus in the same knee twice? And if so, what are your options? Is it the same type of repair the second time?
That's an excellent question as well. In fact, I see patients regularly who have torn their meniscus before and are back with continued symptoms. So yes, you can tear a meniscus in the same knee twice. You can tear it a lot more than twice. And if so, the options really depend on where the tear is. Same as, anytime we address a meniscus tear for the first time, I think our odds of success with the meniscal repair are not as high as they are the first time, because frequently the meniscal tissue, when it's torn twice, is going to be more degenerative, more beat up, and in worse shape generally by the time we get to it. However, that's not always the case, and we're going to do the right thing. And if it's repairing a meniscus tear 2 times or 3 times, we may know that there's a lower success rate, but it may still be the right thing to do. So the options, if a meniscus is torn twice, would be, hey, if this failed the first time, if it's because the meniscus was torn in an area that doesn't have an ability to heal, maybe we should cut our losses and debride the meniscus the second time. However, if it's a recurrent bucket handle tear and it's got good healing potential, we may try and do that, particularly in a young person. We may try and repair that multiple times in order to preserve the function of the knee.
Thank you. How much physical therapy do you need to do after a meniscus repair? So you talked about time and brace and so on, but are you going to be in physical therapy for 6 weeks, 6 months?
I'd say that's very dependent on what you're trying to get back to and the type of repair that's performed. I'll say generally, there's not a whole lot to do in the first couple of weeks other than getting in to see a therapist, establishing a relationship, doing some gentle quad strengthening. But for your first 2 weeks, you may have no therapy, or it may be very light therapy. After the first couple of weeks is when we start working on gentle range of motion and starting to get motion and strength back in the knee. And typically that's going to be 2 visits a week. And after a meniscal repair, it's generally going to be sort of a minimum of 3 to 4 months of physical therapy. That said, if someone is a higher level athlete, trying to get back to a sport, trying to get back to pivoting and twisting activities, 3 months or 4 months may not be enough. We need to make sure that that knee is strong. We need to make sure functionally and structurally that the knee is ready to withstand, potential injuries moving forward. So even after the meniscus is healed, because of atrophy in the muscles and the need for retraining, physical therapy can go on for up to 6 months. So again, not a straightforward answer, and I wish I had one for you, but it really depends on the goals of the patient, type of repair. Generally, it's going to be at least 3 months after a repair, and more often than not, longer than that in the 4 to 6 month time frame.
Thank you so much, Dr. Erdle. That is all the time that we have for today. Would you like to close?
Just briefly, thank you for everyone that tuned in and is watching. I appreciate your attention and support.